First of all, some helpful hints when applying all casts. With regards to positioning, it is critical that the application is done with a degree of comfort. Make sure that the patient, the holder, and the applicator are in the most comfortable position to avoid lifting and handling the problems, and use all aids that are available. Keep close to the patient, bend your knees, and keep your back straight. Have assistance to hold the limb where needed, and do not ask the patient to hold the injured limb themselves, as they will fatigue and become uncomfortable. Insist on help if necessary. The use of the stocking net undercast sleeves. These should not be used if the fracture is being manipulated, and be cautious not to fold the stocking net in over the undercast padding before the first layer of casting material has been applied, as this will cause the stocking net and padding to migrate inside the cast with time. Also, when folding the stocking net back over the casting material before it is set, be careful not to pull it too hard, as it might create a ridge in the cast material, leading to a pressure sore. With regards to the padding, it is best to pad the bony areas with felt, because felt does not compress over time. However, we often use rest-on foam. Casts must fit well, so apply a single layer of undercast padding firmly, smoothly, and evenly. There are many different types of padding available, and it's important to understand which type you're using. The difference between soft band and fell band is something that can be felt physically. Do not make the cast loose by padding too much, as this can allow fracture movement and damage to the skin. With regard to the casting materials, remember that they have different dipping techniques, setting times. The edges are sharper in some than others, specifically in the newer synthetic cast materials. The roughness or smoothness of the outside may vary, and as well as the number of layers required for strength, rigidity, and flexibility. You can use strategically placed slabs to cut down the total number of bandages, but the bottom line is that thick casts are unnecessary. They generate more exothermic reaction during the setting process, and they become more difficult to remove and are very uncomfortable to the patients. Some products allow flexibility, such as soft cast, and these can be used as an advantage, specifically at the edges of the cast. And it's important that you check the variations of the casting material that is being used, and that they are compatible with the patient's diagnosis. With regards to synthetic casting, and the same applies to gypsona, a 1 centimeter overlap on each spiral turn will end up with one layer of casting material. 50% overlap translates to 2 layers, and a 66% overlap to 3 layers. So some important aspects regarding applying a gypsona plaster of Paris cast. Position the limb before starting the application of the cast. Apply felt to any sharp bony areas and a layer of undercast padding. As mentioned, make the undercast padding as uniform as possible. Soak the bandages fully. Roll the bandages on starting at one end. Do not pull, rather roll. Form tucks as necessary to accommodate the changes in limb diameter, specifically in the lower limb. Smooth and rub the bandages continuously to bond and laminate the plaster of Paris or gypsona that is impregnated in the bandage into itself, and hold it still while it is setting. It is important that you avoid any point pressure with your fingers. Use only the flat palm of your hand. Remember that if you do leave a slight dent with a finger, it may translate to a bigger impression internally, which will cause a pressure sore. As mentioned earlier, have assistance to help with holding the limb in one position so that you can concentrate on the application. With regards to a synthetic cast, similar concept applies, but it is more important to have sufficient padding over the bony areas. Remember to soak the bandage completely, but immediately once the foil packaging is released, the bandage does start, or the synthetic casting material does start hardening, and so you do have to start working immediately on opening the bandages, and do not let your assistants or assisting staff prematurely open these bandages. The synthetic cast should be used with caution when there's danger of swelling, for example, post-operatively on fresh fractures, as there is far less give and ability for the cast material to relieve the pressure once it is set. If the cast requires splitting to relieve tightness, it will probably need to be completely bivalved to totally allow relief of symptoms. A gypsona cast can be split in one line. The application of casts and splints is an important part of non-operative management of fractures and has been well described in the literature. Some of the newer products that are available include the one-step or single-step splintage materials such as Dynacast Prelude or one-step splints. These already have padding. It's important to apply them with the padding side against the skin or against the soft tissues, and understand that it takes longer to set. So once the splint has been applied and the bandage has been rolled on, it is important to hold it in position until it is completely set. If you relax that position, the limb will fall into a null position. Also note that the edges of these one-step or single-step splints fold poorly and may need to be cut, kind of like a tailor would do so, to make sure that the edges don't form ridges internally, because these can produce pressure areas. Some examples now of how to put on a below elbow plaster slab. The purpose of using this would be for temporary immobilization of the wrist joint and stabilization of the hand and the distal forearm. The indications would be for wrist sprains and post-operative procedures, and the anatomical position is usually the wrist in 10 to 15 degrees of extension with no radial or ulnar deviation, but this position may of course vary based on the diagnosis that you are treating. There are two options when using gypsona or plaster of Paris. The standard position, which most people are familiar with, and then what I'd like to call is the wet fish concept, where you make a sandwich of undercast material folded over onto a slab that is pre-prepared, and then that is applied in the same way as the one-step, single-step Dynacast Prelude type of fiberglass slabs. This gives the option to use a gypsona slab in the same way as a removable splint. You require delta net or stocking net, soft band padding or fell band, a gypsona or Dynacast Prelude or one of the other fiberglass slabs, crepe bandage, and Co-Plus or elastoform, and in my hands I prefer to use elastoform with elastoplast around that. This is an example of how to do the standard slab, first rolling on the undercast padding and then applying the short volar splint on the volar side of the forearm and into the hand from the proximal, from the 2 inches distal to the antecubital crease to the distal palmar crease, and this should be measured and pre-prepared. The proximal and distal and thumb edges should have at least 3 layers of padding overlapping 100% to make sure that there is a comfortable cuff when the slab is applied. The dynacast prelude is cut to measure in the same way, or the wet fish gypsona to the length determined. The splint is saturated with water, and then it is necessary to wring it out as much as possible, even placing a towel on the countertop and rolling the splint material with the towel to remove the moisture is advised. The splint is then placed on the volar aspect of the wrist in the same way as the standard gypsona splint, remembering that the distal end should stop at the palmar crease and the proximal end should stop 2 inches distal to the antecubital crease so that the patient can flex their elbow. The proximal and distal edges of cast padding should be folded over to prevent splint abrasions, and starting at the wrist using the crepe bandage or the plus bandage, a bandage technique to secure the splint is used. Remember again to hold the wrist in position until the splint is set, and this may take longer than anticipated when using the synthetic casting material. A sling is used if appropriate. It is surprising how often the emergency room staff get this wrong, and here is an example of a patient who presented 3 weeks after a fracture to her wrist for an orthopedic opinion, and you can see that this cast has been applied completely inadequately, slipped right down off the hand, and in fact is immobilizing the fingers, which at this stage will be a significant morbidity and difficult to mobilize. Here is an example of a one-step type splint that was used on a patient, but the wrong way around. The cast padding is on the outside, the hard, rigid fiberglass is on the inside against the skin, and note the crease on the inside which was causing pressure against the patient's forearm. Here is another example of a complication where the elasticized bandaging has wrapped around, slipped off the casting material, and is causing a pressure sore against the skin. So here is 2 pictures which show a volar slab in neutral going from 2 centimeters below the elbow crease to the distal palmar crease, and this is a comfortable position with a functional use of the hand and fingers possible. In the same way as the upper limb back slabs can be applied poorly, so are the lower limb back slabs often applied poorly. This is an example of a patient with a below knee back slab, and you can see that the patient is in equinus, and that in fact the slab goes too high, to just well behind the popliteal fossa, which is going to cause a problem when the patient tries to flex the knee. When do we use a below knee back and side slab, which I'm going to show you now, is when a patient presents with an ankle sprain or a fracture that requires immobilization, but they're too swollen for surgery, so in the immobilization and waiting period, and obviously for post-operative splintage. What you require to make this back and side slab is stocking net. I like to use rest on foam, or you can use felt. 150 millimeter or 6-inch soft band, 3 6-inch or 150 millimeter gypsonas, plaster of Paris, 2 150 millimeter elastoforms, and 1 roll of elastoplast. And what is important that this is unrolled and then re-rolled up before the procedure starts. The stocking net is cut so that it is the length from above the knees to below the toes. The rest on foam is cut into 4 strips so that it can be applied to the metatarsal heads, the Achilles tendon and heel, and both the medial and lateral malleoli. One of the 150 millimeter gypsonas is measured and used as a side slab to go around from the medial to lateral of the ankle, and 2 gypsona slabs are used to form the back slab to go from below the big toe to just 2 inches below the popliteal fossa. Once these are applied, the first elastoform is rolled on, as you will see in the next slides, and the stocking net is turned back over the elastoform and slabs to make a comfortable edge. The second elastoform is then rolled on, and on top of this, the loosely rolled elastoplast is put from proximal to distal. Here is an example. This patient arrived with a fractured ankle, had been placed in the emergency unit into a back slab, similar to the previous example I showed, and you can see that the patient has slipped into Aquinas because the application was done and then the patient was just left on the bed while the material was setting. If you look at the x-rays in the back slab, you can see on the far right hand side the significant Aquinas, but you can also see that the fracture is not at all reduced, and more important, you can also see the number of ridges and indentations caused by the fold of the synthetic casting material, which are causing pressure against the patient's skin. Clinically, once we started removing this back slab, you can see how swollen the foot is, and there's certainly no way that any surgical intervention can be entertained with this amount of swelling. So the patient needed to be put into an adequate back slab in a well-aligned position, and then elevated on a couple of pillows for a couple of days, at least 5 to 7 days before surgery can be undertaken. Once again, a photograph showing the material that I described earlier, gypsona in 2 slabs, the one on the very left made for the side slab aspect, and the one in the center was measured out for the back slab aspect, and that is two gypsonas. There are 2 elastoforms, the rest on foam cut into 4 pieces, the stocking net, the soft band, and on top of the soft band you can see a roll of elastoplast which has been unrolled and then re-rolled up so that it is not too sticky and it can be put on without too much tension. When we finally took the original back slab completely off, we saw also an unmanaged, untreated abrasion on the anteromedial aspect of the patient's ankle, and this required a dressing. The patient was then put onto into an adequate position, and the assistant was made to hold the leg in a comfortable position with her left elbow locked into her side, and then with the stocking net pulled down to get all the creases out, the rest on foam was applied here onto the medial malleolus and over the tender Achilles onto the heel, and the same was done onto the lateral malleolus. And here you can see that the fourth piece of rest on foam is put over the metatarsal heads. Then the soft band is rolled in a uniform manner around the leg. Once the soft band is completely rolled on, the side slab is first put on, and then the back slab as shown. And a point of interest here, the assistant is attempting to be helpful by holding the back slab in place so that it doesn't fall down, and she's using a finger, and this is a negative because if she develops an indentation there, that could cause a pressure sore. What you can also see is that I've asked somebody else to come and help, another pair of hands, to help hold that back slab in place so that the first assistant can take their finger away and we can make sure that that is smooth. The first elastoform is rolled over, and then the stocking net is peeled backwards over the edges, and then the second elastoform is rolled over to make a neat construct. Following this, the elastoform is then rolled over, starting at the top proximally and going from proximal to distal. One entire roll of elastoplast is utilized, and we have gone from a back slab that looked like this with the x-ray that you saw previously to a back and side slab like this, which is far more comfortable for the patient. Some words about a long arm or above elbow cast, a full cast using the soft band or undercast padding. It's important to wrap the elbow joint in a figure-of-8 pattern in order to fully encompass and protect the soft tissues and bony prominences of the elbow. It is always more difficult to work across a wrist and elbow joint at the same time, so having assistance when applying this sort of cast is critical, and it's important to take cognizance of the bony prominences of the elbow and also the area around the thumb and palm, which needs clearance as you would for a below elbow cast, and the cast should also go up to the knuckles, in other words on the volar side to the distal palmar crease, so the patient is able to use their thumb and all four fingers adequately. A few words about the U-slab splint, which is often used for fracture humerus. The purpose is to support the humerus and prevent movement at the fracture site. The indications are for either temporary immobilization of mid-shaft humerus fractures, or often the U-slab can be used for complete definitive treatment of a fractured humerus. It's important to understand that the U-slab works by assisting gravity to have the fracture lie in a reduced position. And the anatomical position is often with the humerus resting on the torso, supported in a sling, and the elbow flexed to 90 degrees. some slides showing how we go about using a U-slab, and for this I often do use synthetic splinting. If you're using synthetic splinting and they come with their own padding, it is not necessary to use additional undercast padding, as this will make the construct too bulky. However, if you're using Gypsona plaster of Paris, one must obviously use proper undercast padding. The application method is to measure the patient's arm length starting 2 inches proximal to the AC joint, going around the lateral elbow and up into the medial aspect of the elbow, stopping 2 inches distal to the axilla. It's usually advisable to over measure this by a couple of inches, as it's easier to fold the edges back than to, it's impossible obviously to make it longer. One would start putting the splint in the axilla, so opposite to how we measured it. You start at the axilla level and come around the medial aspect of the elbow, over the lateral aspect of the elbow, and up over the shoulder. It's often easy to see, get assistance from the patient in this application, as you can see on the picture, by having the patient lean slightly to the one side, allowing the arm to hang like a pendulum, a bell, a ringer in a bell, using gravity to help maintain or hold the reduction. You can see also that the patient is holding their injured arm hand with their good arm hand, so that they stay in that anatomical position. If you have an assistant, ask them to hold the ends of the Dynacast prelude or Gypsona slab in the axilla and over the AC joint. These are the areas where it will slip and lose position. Obviously, starting at the distal third of the forearm, I use a cohesive bandage, a Co-Plus, or an elastiform bandage to secure the splint, wrapping the arm, as mentioned for the above elbow cast, in a figure-of-8 manner to support the cast material against the distal humerus. The patient's then put into the anatomical position that they would be expected to be in the sling. You can see again using the good arm to support the arm, the injured arm, and you can see that the applicator is applying pressure against the arm, holding the anatomical position while the splint material is setting. If a patient has a large upper body, or in the case of a female patient, it is often necessary to do this sort of manipulation or molding, so that you counteract the curvature of the upper chest and avoid the fracture falling into a varus position. Once the cohesive bandage or cramp bandage has been fully applied, it is sometimes advised to go further down the forearm and into the wrist area for extra stability. However, this is not mandatory. It's then important to work out how to splint the patient, either with a master sling or with a collar and a cuff type of method. The master sling is sometimes counterproductive because it can actually support the elbow, push upwards, and defeat the positive reduction effect of gravity. There are numerous ways in which the collar and cuffs can be utilized. Importantly, it must be comfortable for the patient, and they must be advised not to remove it. Just some additional hints about casting materials in general. I've already mentioned them, but Remember to roll the plaster cast or the synthetic material over the arm. Don't pull on it. In this way you'll avoid putting it on too tightly. If you're using plaster of Paris, rub or caress and polish the plaster to bind the powder into of the different layers into themselves. This increases the strength. Remember, if you're using gypsum or plaster cast, when it feels like the consistency of wet cardboard, this is a critical tipping point and it is about to set. If you allow the position to slip slightly at this stage, there will be an inherent crack in the material, which means that the cast will break earlier than you expect. If you want to strengthen a cast over a joint, use the beam strip techniques to strengthen it as one would do in an engineering capacity. Obviously, there's some complications which may affect the healing of the bone or the recovery of the patient, and they may arise at the time of injury or later as the fracture heals, but they also may be as a result of poorly applied casting. The important ones that are in bold include pain, compartment syndrome, deep vein thrombosis, swelling, pressure sores, wound infection, thermal injuries, cast sore, burns or scratches during removal of the cast, and joint stiffness. There are other complications such as null, delayed or non-union, fat embolism, nerve injuries, myositis ossificans, osteoarthritis or allergic reactions which can occur. But splints, and especially poor technique of splinting, can aggravate all of the above. I'm going to address the following: the pressure sores, compliance, reduction, iatrogenic injury, compartment syndrome and vascular disease, cast disease, and record keeping. With regards to pressure sores or cast sores, the causes of these, as I've said a few times in the presentation, is often due to uneven bandaging techniques or insufficient padding over the bony areas. Sometimes the cast can be too tight, but sometimes also too loose, and this allows the development of a pressure sore. And obviously sometimes patients do put foreign objects inside the cast or allow them to slip down to the cast, which can cause a pressure sore. And finally, a finger or an object causing a dent on the outside of the cast while it is still soft can cause a bigger impression on the internal surface, which can cause a pressure sore over time. The prevention is obviously good casting technique, as we've discussed. The signs and symptoms include a burning or blister-like pain. So if your patient presents with a burning type of symptom under the cast, it behoves you to remove that cast and look for a pressure sore. The later signs include local heat, if there is infection, offensive smelling, staining of the cast, and fever. Treatment. If it is early, one can simply cut a window in the cast for inspection, but bear in mind that local edema will cause the soft tissues to bulge out of this window if left open. So the window must be replaced or closed by either temporarily strapping it back into place or permanently replastering it. Sometimes a new lid has to be made and strapped into place. If you're worrying that a foreign object is the cause of the problem, an X-ray could be helpful, and it may be necessary to change the cast. Early treatment is mandatory because after a couple of hours the skin actually dies from prolonged pressure. The pain initially disappears until an ulcerated septic area develops, which can then actually erode all the way down to bone and take many months, requiring often plastic surgery to recover. There is an example of a lid that has been made so that it can be taken on and off to inspect the underlying wound in the cast. Compartment syndrome, you should know about compartment syndrome unrelated to casts, but it's good to revise it, the concept, when it comes to a cast. So groups of muscles are surrounded by fascial sheaths which create compartments containing muscles, blood vessels, and nerves. If there is an increase of pressure within these compartments, you can develop what we call compartment syndrome. The rise in pressure may reduce the blood flow locally to the muscles and ultimately lead to tissue death and, if left unattended, loss of the limb. So early diagnosis is essential because one of the treatment modalities includes a fasciotomy, which needs to be taken as an emergency. The indicators of developing a compartment syndrome is increasing pain, which is out of proportion to that would be expected by the injury. If there is suspicion, pain on passive movement of the extremities of the digits is also noted as a sign, and pain that does not respond to analgesia. In the late cases, the patient may present with pins and needles, numbness, and muscle weakness. The pulses initially distally will be normal, but increasing weakness of pulse may occur as the compartment syndrome progresses in the later case. Treatment of compartment syndrome of a patient who is in a cast is as follows. One must bivalve the cast and split it all the way to the skin. Do not leave any strands of undercasting material in place because this may be enough to maintain the compartment pressure. Remove the limb from the cast and examine it in most instances, and elevate it, but not above the height of the heart. If the symptoms persist, one would consider a fasciotomy. Some words about a iatrogenic injury. This is actually usually caused by the procedure, and it's often due to careless application and a tardy response to the symptoms by the attending physicians. One can get circulatory and nerve impairment due to unexpected excessive swelling or the cast being applied too tightly, and sometimes a combination of these two. When a surgical procedure is done under tourniquet, there can be swelling afterwards, and if a tight cast is applied that does not allow for the swelling, the patient may get circulatory and nerve impairment. Also, there might be insufficient padding or local pressure on the areas where blood vessels or nerves are noted to be close to the skin. The nerve compression will give the paresthesia sensation, and arterial compression will cause the limb to appear first white, then blue, and finally black, and the limb will be cool. Capillary refill is also an indication of whether there's circulatory impairment. The treatment will be elevation in the early phases, unless you suspect a compartment syndrome where you may need to bivalve the cast. Sometimes it is difficult to differentiate between the two, and it is advisable then to split or bivalve the cast, as mentioned under the compartment syndrome section. If there's local pressure on the nerve, simply windowing the cast over that area may be useful. What about thermal injury during application? So both plaster of Paris and fiberglass materials harden as an exotherm reaction, and the materials become hot as they set. They may become hot enough to cause a burn to the underlying skin. The factors that increase this risk is the temperature of the dip water. In the past, we used to advise the dip water to be fairly warm, just below 50 degrees centigrade, but recently the recommendations are to keep it below 24 degrees centigrade. The warmer the water, the faster the casting material will set, and the colder the water, the slower it will set. So the colder water gives more time for the application and molding of a cast. There may be an increase in the number of layers of the material, which will then produce increased heat. You normally are going to be advised to use about 15 layers of gypsona when applying a plaster cast, up to 20 to 24 ply. A common mistake is made when placing a 15 ply splint that is slightly too long. So the end is folded over, which obviously creates a portion of the cast that's 30 ply. This is above the 24 ply, and this is an increased risk for thermal injury. Obviously, if there's less padding, it'll allow more heat to reach the skin, and it's advisable that there are between 2 and 4 layers of padding throughout the cast, with more of the bony prominences. If you put a pillow or blankets beneath the cast and then over the cast, they may insulate the heat they produce and keep it around the limb instead of letting it disperse into the surrounding air, and this may cause a thermal injury. Using alcohol or another agent on the outside of a curing cast to decrease its temperatures has been advised, but this has been studied and is shown to have no reliable effect. Remember, if you apply more rolls to a cast for strength, rather allow for a few minutes for the original cast materials to cool off before applying the second layer. With regards to non-compliance, many patients do not know how to assess how to manage their plaster casts, and you need to assess the patient's ability to protect the cast, review their social circumstances, and always provide a sheet of tips on how to manage the cast, what we call a POP form. If it's a child that you're dealing with, make sure you give the POP form or cast form to the parents. Loss of reduction, of course, can occur within a cast, specifically when a cast is fitting snugly and then the swelling goes down over a few days and the cast can become loose and require revision. And a high index of suspicion must be used, and follow-up is important to make sure that this does not happen. But properly applied and well-molded casts reduce the risk of this happening. And serial x-rays, certainly a repeat x-ray immediately after applying a cast to make sure the position of the fracture is maintained, and then at the 1 week stage after the cast is applied would be advised. If the reduction is lost, this can sometimes be salvaged by what we call cast wedging. If the fracture is still fairly fresh and the fracture site is still expected to be mobile, the cast can be partially cut and wedged in an attempt to reposition the fracture. X-rays are used to measure the appropriate place for the cut to be made and the direction of the wedging to be performed, and one can do an opening wedge or a closing wedge type of manipulation. Straight after doing the wedging, repeat x-rays should be taken to confirm an improved position of the fracture, and then the cast can be completed around the wedging area to maintain that position. Of course, if the fracture is immobile or requires manipulation that cannot be done by wedging alone, the cast needs to be removed for repeat manipulation and placing a new cast. And remember that cast wedging will not be able to address a shortened fracture requiring length. So ultimately, if the reduction cannot be maintained in a cast, surgery may be necessary. What about the concept of cast disease? This is in fact a complex regional pain syndrome that often occurs or has been noted to occur when people are left in casts for too long. With this cast application, it probably relates to nerve injuries, and there have been many different names in the past. There is a gate theory of spinal dysreflexia that is supposed to be responsible, and the cast disease is characterized by osteopenia and stiffness and disuse of the arm, and the bone scan is uniformly hot. Treatment, however, is controversial. Prevention is important, and making sure that you apply a comfortable cast and you keep the digits moving, and the patient is aware of their cast management, that will usually avoid the development of this complex regional pain syndrome. And finally, record keeping. This is essential. One must document all information: the type of fracture, the date of application, the instructions given to the patient, the therapeutic plans, making sure that the patient understands this. Removal of the cast, there's a specific technique using an oscillating saw. Remember that it's important to show the patients that the saw does not spin but actually vibrates. And the cast is removed by utilizing a series of up and down motions combined with linear movement. You hold the cast removal unit with one hand, move the switch to on, and then using the thumb or the forefinger as a gauge to press the blade into the cast. The blade should be pushed down and then lifted up slightly, moved and pushed down again and then lifted up slightly. This should be done in a steady way, going along the length of the cast, and do not exert excessive pressure. Here is another illustration of how the cast should be removed. Remember never to drag the blade across the cast because it may scratch the skin. And finally, also remember that when specifically with removing synthetic casts, the blade can get really hot, and sometimes you have to pause, allow the blade to cool down before proceeding so that you don't cause a thermal burn.